So good afternoon, everyone. This is a session which is uh, known as the 7 investigative tools in ophthalmology, tips and tricks. And the 7 topics that have been chosen by will be taken up by 7 people who are primarily one of the most experienced people in their fields. So without wasting time, I would like to invite Dr. Sujit Kumar Mishra. He'll be dealing with the topic toric tips and tricks. A brief introduction. He's a uh, he's MBBS and MS from DMCH Darbhanga. Basics and clinical sciences ICO he has done. Phaco in cataract and phaco surgery. He has the qualification of anterior segment fellowship he has done from Arvind Eye Hospital, Tamil Nadu. He's an ex-consultant and CMO from Lotus Eye Hospital, Tamil Nadu. He is the chairman scientific committee of Patna Ophthalmic Society. He is the editor of iQuest, which is published by Bihar Ophthalmic Society, and he is having his own clinic at Patna also. So over to you, Dr. Sujit Mishra. And before you start, may I request the senior people, Dr. Jagopal Agarwal, to please take the dais.
Thank you very much, sir. At the outset, I would like to thank Dr. Pranav Ranjan, sir, who is currently president of AIOC, for giving me this opportunity. So I'll be talking on tips and tricks for the toric IOLs. I have no financial interest. We all know that be it the global or Indian scenario, for astigmatism more than one diopters, we have more than 40% of cases who are undergoing cataract surgery. At the same time, the outcome of toric IOLs have become very predictable in terms of the investigative tools and the lens design we have, and very good rotational stability is there. So we are standing in a situation where we have very good understanding of corneal astigmatism, we have very good capturing devices, we have from manual marking to image guided system for appropriate orientation of the lens, and lenses with better rotational stability. So toric IOLs are the need of the hour. I'll take you back to 2011 when I did this case. This young boy in teens had corneal tear with lens trauma. I did aspiration of lens, corneal tear repair, and there was no intact capsular access. Still, I decided to implant a toric IOL that time, and a patient could read 6/9 unaided. So with this basic platform, I introduce you to the 10 commandments of toric IOLs. First, that is the myth associated with it, that it needs lot of instrumentations. Patients in my region are not willing to pay extra, or residual astigmatism, if left, will lead to unhappy patients. It's not like that. You have to do a good counseling and you try. Never jump to the conclusion of toric IOL implantation based on refraction only. You have to look at the corneal astigmatism and then you counsel the patient about astigmatism. And case selection is very important. It is very important to understand how a phaco in toric IOL differs from phaco in routine cases, because you may have to spend some time preoperatively in marking. Intraoperatively, you have to orient the lens in proper meridian. And if pupil comes down, then you will have difficulty in identifying the mark points on the lens. Then dry eye evaluation, any corneal opacity, and posterior segment proper evaluation should be there, otherwise it may affect the outcome of the patient. Here if you see, this patient on lens star we are trying to capture, and very poor patient cooperation is there. If patient has very much dry eye, he may not able to fixate on the target. So what reading you are getting is not appropriate. So in this case, toric IOL is being implanted and pupil has come down heavily. So after implanting the lens, it is difficult to identify where are the marks. So I have to retract the iris to see the 3 dots exactly. And now you can see, I'll be able to see those 3 dots. Yeah, now you can see. So I tried to align this IUL by rotating, but what happened? In the meantime, I saw there was excessive rotation of the lens. So what was the problem in this case? That one haptic was in the bag, other was in sulcus. And retrospectively seeing the video, I can make out, but on table I couldn't. So I missed this case. So there was gross rotation. So I had to align it again. Second thing is which case you should take up with high astigmatism or low astigmatism. So a lot of considerations are there. If you take up small astigmatism, you will be missing if orientation is not proper, residual will be low. If you are taking high, if rotation is there, then high residual will be there. So based on that, the bottom line is the counseling should be proper, then only you take up the patient. Then it's about measuring the correct astigmatism. Apart from the what I said earlier, you have to take into account the head tilt and cyclotorsion also, because these affect the measurement of axis of astigmatism. Then when you are doing optical biometry, the only data that you can look at to validate your examination is the standard deviation for all the parameters that you have. In A-scan by ultrasound biometry, you can look at the graph, A-scan spikes and interpret. But here it is the standard deviation that will give you insight about whether your measurement is appropriate or not. Then posterior corneal astigmatism has emerged very heavily, and we have to take care of that. Barrett toric calculator theoretically takes into account of that posterior corneal astigmatism, and there is a fair amount of agreement between this predicted PCA and actually measured PCA. So if you don't have an instrument which actually truly measures PCA, this Barrett theoretical assumption will help you in your astigmatism cases. Then this Baylor nomogram is for with the rule and against the rule astigmatism of posterior corneal astigmatism. So if against the rule means if everybody is against you, means you are weak. If everybody is with you, this I am telling you the mnemonic to remember. So if it is against the rule, means you will be underestimated. And if everybody is with you, you will be overestimated. So if you remember this mnemonic, you can always remember that in against the rule astigmatism, you have to lower the threshold, and with the rule astigmatism, you have to up the threshold. So knowing your SIA is also very important. It can be calculated online. Then we have online incision location also on LensStar. You can manipulate to see how much residual astigmatism is there, as you can see on this in this video. Earlier we were dependent upon only the what company gives us, but here in real time scenario you can adjust your location to look at a feasible location as well as the residual astigmatism. Then biometry should be proper. Then one thing, if in LensStar, suppose whatever Barrett formula is there, that at the time of installation, whatever updated version is there, that will be installed. But the online is always updated. So it's not that online, if you are using it is because you have not paid for that, it's free, so it's not good. No. It's very updated, so there is no. It's not wrong to use the online Barrett calculator for marking. If you have image guided, that is the best. Otherwise, you can equally rely on manual marking, and 3-point marking is a good option. Then knowing the type of lens you are going to use is also very important, because if it is plate haptic lens and if it comes out of the bag and pupil has come down, I have till date in premium lenses only one case I had a complication. That was the plate haptic toric IOL. I was trying to push it and I pushed it very much, and that plate, it torn the capsule. So you have to keep that in mind. The lens design is also very important. And then washing the viscoelastics from behind the IOL is also very important. Otherwise, there will be a gross rotation. Many times we see my post-operatively it rotated this much, that much. No. Lenses are very good. They adhere to the capsule very well. So washing viscoelastics is very important. So to conclude, microscope should be coaxial. Undershoot the desired meridian so that you have little room to adjust the toric IOL along the appropriate axis. And if there is a collapse at the end, then re-ensure the orientation, because collapse of chamber may rotate the lens little bit. So thank you very much.
Thank you, Dr. Sujit, for comprehensive tips
Thank
that
you,
you have
sir.
given. One thing which always comes to the mind is the cost factor between manual marking and a digital marking system. So what I have, my experience is manual marking is equally good, and therefore what I advocate is that it should be taken up by every surgeon who is doing a cataract surgery.
Absolutely. That is
So
why
that should
in
not
the
be a
first
bar,
slide,
because the margin of error is very, very minimal. Do you
absolutely. That is why the first slide I put was myths about toric IOL. It needs a lot of instrumentation. No. The first slide was no. With manual marking, you can do it very
And a
well.
marking on the slit lamp, 0 to 180 degree,
Very
with a
impeccable.
26 gauge needle.
Yes.
I mean that gives you a precise axis.
Yes.
So that is one thing which I have learned, that there's hardly any difference between a manual marking system, the ultimate result, and the
Yeah, I didn't add the video because of lack of time,
Right.
but I
So this
just
is one
passed
thing
by
which has-
mentioning 3-point marking what I
Yeah.
showed.
And
Absolutely, sir.
everyone who is doing a cataract surgery, this is a very, very forgiving surgery.
Yes.
Toric implantation.
Absolutely.
So everybody should take up toric implantation.
And we have a lot of cheaper lenses available now
Yeah.
for toric.
Yes.
So
And it doesn't
should be
cost
used.
anything. It doesn't
Yes.
cost anything
Yes.
extra except for your skill.
Yes, absolutely, sir.
Okay, thank you
Thank
so
you.
much.
Dr.
So
Sujit,
you are a
you
senior
have
person.
mentioned
Please take a
another
chair
thing,
here.
very important thing,
Please
that
take
the
a chair.
online Barrett Tori calculator is better than whatever we have been supplied in the IOL Master 700 and others. Or every time I have gone through both two, online Barrett Tori calculator is better than whatever I have been given, provided by the IOL Master 700.
Yes,
So
absolutely.
online-
This is very important
This is
point.
very
That's why I
important.
highlighted. So never feel that you are using the free version, so it's not something up to the mark. No, that is more updated.
Yes.
In your machine, once installed, then installed. But there it is currently updated.
So it is very important to use online Barrett Tori calculator.
Yeah. Thank you, Sujit. You take a chair here. And the second presenter, we have Dr. Pranita Sahai. She'll be taking up the topic of corneal topography. Right? She's an assistant professor in Maulana Azad Medical College, and she'll be dealing with corneal topography. She's a MD, senior resident from RPC AIMS, Delhi. So, Pranita, please.
Thank you. Thank you for that kind introduction. So good afternoon, everybody. I'm Dr. Pranita Sahai, and I'll be discussing about corneal topography. So basically, first what we need to understand is what is topography and tomography. So while topography assesses the shape of the corneal surface, tomography gives you a three-dimensional assessment of the cornea. That is, it gives you a true estimate of your posterior corneal contour. So the Placido-based topography systems, that is your older version of OpScan and video VKG, were your topography system, while the Pentacam Galilean series based on the Schimflug imaging are your corneal tomography system. Obviously the tomography is a more advanced system, gives you a better assessment of the cornea, and hence that is what is most widely used these days, and that is what I'll discuss in the presentation today. So basically the idea of the tomography came with the Schimflug imaging, which was first conceptualized by the Theodor Schimflug himself. The Pentacam has two cameras. One has a central camera which gives you a detection of the pupil size as well as the fixation, the central fixation of the eye. The second camera has a rotating Schimflug camera which captures 360-degree image of the eye. But the camera rotates only 0 to 180 degree so that the nasal shadows do not cast a problem in image capture. Now the light source that is there, you all need to know that the Pentacam or topography images are captured in dark room. Hence, so that the image of the eye is captured, there are UV-free blue light inbuilt in the Pentacam system that helps in capturing the eye images. It utilizes a ray tracing algorithm to construct and calculate the anterior segment image, and even minute movement of the eye can be detected by these machines, and it will reflect onto your quality of scan when you're looking at the images. So as I told you, it captures images in 0 to 180 degrees. Slit images are captured. Almost 50 images are captured in just a fraction of 2 seconds. There are 2760 elevation points in each image. A total of 1,38,000 true elevation points are estimated. That is, even minute changes in your corneas will depict in your interpretation images that you will see. Now, as the name reflects in pentacam, it reflects that it assesses 5 parameters. The 5 parameters are pachymetry, corneal topography, anterior and posterior corneal curvature, astigmatism determination, and Scheimpflug photography of the lens. So when you start capturing an image of pentacam, this is the first thing that you see on the screen. On the right bottom that you see here is the guide for your joystick. How do you want to move your joystick so that a central fixation of the eye is obtained. So it gives you a guide whether you want to rotate the joystick up, down, forward, backward, so that a proper centered image of the eye is captured. It automatically detects whether a right or a left eye is being detected, is being captured, and this is the Scheimpflug images that is currently being assessed. Now, once you capture the image, which will be captured in just 2 seconds, this is the first image which will reflect on your screen. So on the top, what you can see is the camera slit position image. As we said that there are 180 degree, 0 to 180 degrees captured, different angles are being captured. So if you want to look at any specific particular angle, you can change these segments and look at that particular angle only. On the right top, you will have the patient data and you will have the keratometry values. And this map is variable. You can choose which map you want to see, whether a pachymetry map or a curvature map or an elevation map. And on the bottom left, you get a 3-dimensional model of the anterior chamber. Next, we'll move on to the specific characteristics that you want to look at the map. So before you interpret any map, you first want to know whether you should read this map or not, whether the quality is good or not. That depends upon this QS value, which is the quality specification scan. That needs to be okay. So then only you proceed to read the scan. If this area is in yellow or red, that means the scan is not appropriately captured. There may be blinking of the eye, or lid opening may not be adequate, and hence you want to repeat the scan before you go on interpreting it. Next is the Q value. The Q value is just below the QS. It gives you an idea of the shape of the cornea. Normally the cornea is prolate in shape, that is centrally steep, peripherally flat. In such cases, normal value is 0 to -1. If your value is reaching up to -1, that means it is hyperprolate. Usually in keratoconic eyes is that what you see. And in patients who have undergone myopic LASIK or myopic photoablation, the shape usually becomes oblate, wherein central cornea becomes flat, values will become positive. So this Q value can give you an idea of the shape of the cornea. Then there is a concept of reference body or a reference sphere. So these machines have certain reference spheres, which can be a reference sphere or a reference toric sphere, with which the patient's curvature is matched, and a difference map is given which reflects as your elevation map, which will tell you whether the patient's curvature is over and above the reference sphere or below the reference sphere, reflecting in your elevation maps. Every map is color coded in this. You see beautiful colors from blue, green, red, yellow, all colors. But what do these colors mean? You need to understand. So in elevation maps, blue means flat, red means steep, that is elevated over and above your best fit sphere. So over and above a reference sphere, if the patient's cornea is steep or elevated, that will reflect as plus or red, and if it is flat, it will be below your reference sphere, it will be blue or minus values. So this is a representation of an elevation map. In normal corneas, as I told you, it is prolate, so central steep. What you can see, this yellow line is the patient's corneal contour. It is going above your reference sphere, which will reflect as yellow or red in your color map. In the mid periphery, it is dipping down your reference sphere, hence the cooler colors blue. In the periphery, again, what you see is it is going above your reference sphere, hence the hotter colors yellow and red. So that is how your color coding of the maps is done. Moving on to the pachymetry map. Here, cooler colors depict thicker corneas and hotter colors are thinner corneas. So in this map, what you can see is paracentral area is red, that is thin, and this thinning is decentered. So that is what you most commonly see in keratoconus. You see thinning and decentered thinning that will be reflecting on your color coded maps. Now this is the holistic 4-quad map that you see most commonly, that you read for any patient. So how do you go about reading it? As I said, first you look at the quality of scan, that looks okay. The Q value here is -0.99, red flag, looks like patient may have keratoconus. You look at the curvature map on the left top, you are seeing hot colors. That means the cornea is steep. You look at the numeric display of keratometry. The keratometry is going up to 51. That means it is over and above the 47 cutoff that we consider for normal corneas. That means the cornea is steep. You go on to looking at the pachymetry. You again see red colors. That means the cornea is thin. And the thinning is corresponding to your steep cornea. That is, thinning and ectasia or steepening are corresponding to each other. Most commonly, that is what you see in keratoconus. Again, you look at the posterior elevation. Again, the site of the posterior elevation is matching with your steepening and thinning. That is pathognomic for keratoconus. The next map that you read after the four-chord map is the Bellin-Ambrosio enhanced ectasia display, wherein came the concept of the enhanced best fit sphere. So while the best fit sphere, the enhanced best fit sphere excludes the central 3 mm area of the patient's keratometry value, the steepest keratometric area, and because of that you get a flatter best fit sphere, and even form frustrated keratoconus or subtle elevations will be depicted there. Two other parameters that are seen in the Bellin-Ambrosio enhanced ectasia display is the corneal thickness spatial profile, wherein the thickness from the center to periphery is measured in this pattern, and the percentage thickness increase, that is the percentage by which the thickness is varying from center to periphery, is measured. The two dashed lines represent two standard deviation, which is the normal range. Anything going above and below it is abnormal and should be looked into. So this is the holistic Bellin-Ambrosio enhanced ectasia display, wherein you see the posterior elevation, although showing red, this red colors are getting enhanced into the enhanced ectasia display and is reflecting on your difference map. I'll just take one more minute. So these are some parameters that you need to remember whenever you are assessing any patient for topography. There are subtle findings that these are basically theoretical, but you need to remember these values so that you can identify patients of keratoconus and form frustrated keratoconus. Most important is the posterior elevation, which should be more than 17. Anterior elevation, if more than 12, is abnormal. So this is just 3 cases I'll show. In this case, what you see is you have a with the rule corneal astigmatism. Cornea is looking steep, but when you look at the thickness map, the thickness is normal, posterior elevation is normal. So this is just a normal steep cornea with the rule astigmatism. Again, now this is a patient with a steep cornea. You are yellow in the center, but there is some thinning associated with decentration that you see in this map, and that is indicative that the topography is not absolutely normal, and you would like to repeat this topography maybe after 6 months if the patient is coming up for a refractive surgery. D value again is important, which if is above 2 means that is a red flag sign, and you need to repeat the topography after some time. Just the last map. This is a map of a patient with pellucid marginal degeneration, where you see a classic crab claw appearance, that is kissing dove appearance. The inferior cornea is steep and the thinning is just above, is not exactly corresponding to your area of steepening, unlike keratoconus where the two areas correspond absolute to each other. So with that, I'll just conclude because it's an extensive topic. So
what is the take-home message, especially for people who are not too much used to corneal topography readings and all?
Yes.
So what is the take-home message?
So the take-home message is at least you should be able to understand the 4-chord map, so that once a patient comes with you a map and you see hot colors, red colors, you should be able to identify, yes, the topography is not normal, and at least keratoconus is something that you should be able to pick up, wherein you should see whether the steepening, thinning and elevation, all if are corresponding to each other. That means you're looking at it ectatic cornea. So definitely screening before refractive surgery or planning for any surgery.
The pachymetry map is also important. That has to be correlated basically.
Yes, correlating the 3 important maps,
So
the pachymetry, elevation and curvature.
Thank you so much.
Thank you.
So we have the next speaker, Dr. Aditya Anand. He will be talking on macular function tests in opaque media. So he has done his DNB from Arvind Eye Hospital, Pondicherry. He's a fresh, young, knowledgeable person, and he'll take us through the macular function tests in opaque media. This is a very interesting topic.
Good afternoon, everyone. I will be dealing with macular function tests in opaque media.
So mic
Yeah.
keep your mic near you. Yeah.
Hello. Yeah. I'll be dealing with macular function tests in opaque media. So you will give a general background of what is anatomical background of macula is a round area at a posterior pole temporal to the optic disc, which is 5.5 mm in diameter. It comprises of fovea centralis, foveola, and foveolar vascular zone. And those are specific anatomic configuration of the fovea has the densest concentration of cones, a 1-to-1 photoreceptor ganglion cell relationship, cones more elongated and slender, its absence of rods at the foveola. RPE cells are taller, thinner, and deeply pigmented, and presence of xanthophyll pigments. It gives a highest discriminative ability or color perception. So why we should look at the macula? So it has a clinically compelling situation such as vision which is not resolved, improve after cataract surgery, after refraction, referred cases with unexplained vision loss, children with strabismus, and the pointing symptoms such as inability to read fine prints, metamorphopsia, minification, magnification, obstruction, positive or negative scotomas, or color vision changes. So basically we have to do this macular function test to look at those symptoms. So MFT macular function test with either can be done in the clear media as well as with the hazy media. So here I will be discussing about only the opaque media. So just we'll go through like what are the MFT with clear media: visual acuity, contrast sensitivity, slit lamp biomicroscopy, photo stress test, color vision, Amsler grid, microperimetry, FFA, and OCT. And opaque media, the MFT tests are the Maddox rod test, focal ERG, VEP, laser interferometry, potential visual acuity meter test, and top tick phenomena, preferential hyperacuity meter perimeter, and B scan. So one by one we'll just go through the important points of each test. So Maddox rod test, here the patient is asked to fixate light either at a distance of 33 centimeter, which is a near distance, or a far distance of 6 meter through Maddox rod with opposite eye occluded, and it converts the point source of light to a line that is seen by the patient. The Maddox rod is rotated vertical, horizontal, and oblique, and the patient is asked what direction the line is oriented and whether the line is continuous or not. So any breaks or hole, discoloration, distortion indicates a macular lesion. So the responses of Maddox rod test are noted as the 4 graded response. So grade 1 response will be like a patient can identify the direction correctly in all 3 positions. The line appears straight, continuous, correct in color in all 3 positions, which indicates 6/6 or 6/9 vision. Grade 2 response, the patient can identify the direction correctly in all 3 positions, but line appears straight but broken and correct in color in all 3 positions. And grade 3 response, it identifies the direction color but is unsure whether the line is straight or not. And grade 4 response, the patient can correctly identify only color. So focal ERG, here ERG is only abnormal when a large area of retina is functionally impaired. So it's a record of changes in the eye's resting potential caused by a flash of light. It's a summation of the action potential of the retina and is used to record the integrity of the rods and cones, bipolar cells, and retinal pigment epithelial cells. So ERG procedure, I'll just go through fast here. So there are 3 electrodes which we use here: active electrode, reference electrode, and ground electrode. So active electrodes are put either in the corneal either as corneal contact lens, gold wick electrodes in the conjunctival sac, or gold foil electrodes on the eyelids. Reference electrodes will be placed at the lateral canthus, ground electrode placed at the nasal canthus, and a Gansfeld stimulus is used to stimulate the retina, and the changes in the resting potential are recorded as a graph. So first, scotopic ERG is first performed after pupil dilatation and after dark adaptation for 20 minutes, and increasing intensities of the stimulus are presented to the retina, and recordings obtained are referred to as a dark adapted ERG. In a photopic ERG is performed after 10 minutes of light adaptation, and increasing intensities are presented to the retina, and light adapted ERGs are recorded. And there are the 3 types of ERG: full field ERG, pattern ERG, and multifocal ERG. So ERG is recorded as shown in the graph. So here the A wave is a small negative wave that originates from the photoreceptors. B wave is a large positive wave that originates from the bipolar cells, and C wave is a slow rising positive wave originating from the RPE cells. And here there are 3 terms which we should know: amplitude, implicit time, and latency. Amplitude is a maximum of the measure of the maximum deviation. Implicit time is a time interval between the onset of the stimulus and the maximum response of either A wave or B wave. Latency, the time interval between the onset of the stimulus and the start of the wave. Next, we come on to critical flicker fusion frequency. It is defined as the frequency at which the flickering light can be perceived as continuous. It is used to access the processing of temporal vision, and critical fusion flicker fusion threshold, which denotes the fastest rate of flickering light that the visual system can see, and is used to characterize visual processing. And during the critical flicker frequency test, the patient is asked to fixate on a light emitting diode that emit light and that oscillates at a gradual increasing frequency, and patient is asked to press a button when they believe the light to be continuous. So this is reduced in retinal and neural diseases, but resistant to degradation due to media opacities. This is how it is recorded. Here the flicker sensitivity curve is plotted for a given point on retina as a function of flicker frequency, and a minimum modulation depth at which the test spot is barely perceived to be flickering is defined as a threshold modulation, and this is what we measure, which is the reciprocal of which is called sensitivity. Dark adaptation, it's a done by Goldman-Vickers adaptometer. Normally the whole process of dark adaptation requires 15 to 30 minutes. And here the subject is exposed to intense light that bleaches photoreceptors, then suddenly placed in dark, and the flashes are repeated at regular intervals, and sensitivity of eye to light is gradually increased, and we get the reading as a curve. So this is the dark adaptation curve, in which we can see the cones are more sensitive in the starting, then rod cone break happens, and then rods are more sensitive, and gradually it remains for a longer time. The clinical applications of this are the disorders of pigment degeneration, neural adaptation, chloroquine toxicity, retinitis pigmentosa, high myopia, glaucoma, and retinal degeneration. VEP is also an electric potential generated in response to visual stimulus. Here the macula has the largest representation within the visual cortex, so VEP produces a macula dominated response. So here done in two ways. In the two systems of placement of electrodes are there, 1020 international system and Queen square system, and it is of two different types of VEP, flash VEP and pattern VEP. So flash VEP is presented to the eye at a rate of 1 to 5 times, and it indicates if the stimulus was perceived by the cortex or not. It's a test of choice of infants, and it can be done during sleep. And pattern VEP, it roughly estimates the visual acuity in a checkerboard pattern. So we should remember the three waves here. Positive waves are P100 wave, and negative are N75 and 135 waves. Here, if the largest amplitude fastest waves are produced with a checkerboard stimulus with 5 to 6 mm squares, the visual acuity can be estimated to be around 20/20. But if the largest amplitude fastest waves are produced within larger checkerboard stimuli, the visual acuity is correspondingly lower. Laser interferometry, here we produce the interference stripes of fringes that are projected onto the retina. Beam produces 2-point sources behind the lens opacities. So here it is able to predict acuity up to 20/20. I'll just take one more minute. Yeah. So a spatial frequency of 30 per degree is equal to 20/20, 6/6 visual acuity. The different models available are Heinz lambda retinometer or Lotmar visometer, and advantages of this are unaffected by the optics of the eye, and it is more accurate than potential acuity meter. Here the patient pupil is dilated. The interferometer is used to project a fringe pattern onto the retina. The patient is asked to recognize the direction of the fringes, vertical, horizontal or oblique, and the fringes are made finer until the patient is unable to identify the orientation, and the endpoint fringe pitch is noted and correlated to the Snellen's visual acuity using a chart provided. The limitations are in the tilted retinal receptors or healthy photoreceptors in CME, it gives a false positive test, and false negative in a very severe dense cataract, dense VH or poor pupillary dilatation, false negative test. This is again a device PAM. It is used in predicting the post-operative visual outcome after cataract surgery in patient with retinal pathologies like dry ARMD and those with choroidal neovascularization, and it can also be used to predict vision after Nd:YAG capsulotomy in patients with posterior capsular opacities. Here we can see that inverted Snellen's acuity chart is projected onto the retina, and the smallest Snellen line where the patient can read 3 or more characters is recorded as the potential acuity. And there are 3 antoptic phenomena, Purkinje vascular antoptic phenomena, flying spot and Heidinger brushes. The vascular phenomena, it elicited by the response by placing a pen light against a closed eyelid or the globe and moving it back and forth and creating images of the patient retinal vascular tree. Flying spots, these are the movement by the leukocytes, and it is in a curved sinusoidal patterns and takes the stimulate the capillary loops of the vascular tree. Here the point to be noted, if the intraocular pressure is above 50 mmHg, the moving ceases and then we can't see the flying spots, and the background illuminated by the blue light in spectral region of 350 to 450 nanometer. And coming on to the last, Heidinger brushes is a phenomena caused by variation in absorption of plane polarized light by oriented molecules of xanthophyll pigment in the foveal retina, and is used to sensitize the fovea in amblyopic child with eccentric fixation. And hourglass shaped yellowish brushes seen radiating from the point of fixation, and rotating polarizes the brushes also rotates. So if the patient can perceive shadows of the arborizing retinal vasculature, the macular function is probably normal. If they cannot perceive the vasculature, macular function is probably poor. Similarly, in the blue field antoptic phenomena, if there is a partial loss in movement, a complete loss, or a slow movement, the retinal function is abnormal. Okay.
Aditya, can you sum up? Yeah, because
okay, I'll just go sum up the important.
I mean, what are the important tips that you want to give, especially for patients who have got corneal opacity?
Okay, I'll just okay. So if there is an opaque media or a dense, severe dense cataract, or
what are the tests that will advocate to the ophthalmologist?
Basically,
because we do not have all the gadgets.
Yeah, yes, sir. So basically, we go through like we generally perform ERG or VEP tests, or in a very semi-opaque media, we use a Maddox rod test.
The first test that you said, that is more practical, the Maddox rod test.
Yes,
that gives you.
Yes, but that can be used always. It's even in the very severe dense cataract or dense posterior segment pathology, we can't use that also. But in a semi-opaque media, we can definitely go ahead with that.
Then the second test is the ERG, which is specific.
Yes, ERG and VEP. And since the time is up, so we can't discuss the other. There are a lot of tests which are recently also, a lot of new innovations are coming on this.
Okay, thank you so much.
Yeah.
Thank you.
Thank you.
The next speaker we have is Dr. Devesh Kumawat. He will be giving us tips on OCT. He's a graduate, postgraduate and senior resident from RPC AIMS, presently assistant professor in RPC AIMS Delhi.
Thank you, sir, for the kind introduction. So, optical coherence tomography is basically an optical biopsy of the tissues, and it is performed using the principle of low coherence interferometry, wherein you have a light source which is splitted by a beam splitter, and one beam will go to the reference tissue. One beam will be the reference beam, it will go to the reference and it will reflect back, and the other beam will go into the patient's eye through the optical system, and the reflected beams are then detected and analyzed by the OCT software. Now, multiple A scans are combined to give you a two-dimensional image, that is a B scan. So you have a B scan which is in the XY longitudinal plane, and in the coronal plane, if you see, it is the NFAS image or it is the coronal scan, that is the C scan. So we have A scan, B scan and C scan. A scan is at a particular point, and if you have a conglomerate of multiple A scan points, then you get a B scan image, and then the B scan image is will provide you a cross-sectional image, whereas a C scan image is in the vertical plane, that is in the coronal plane. So there are different domains of OCT which are available. Nowadays we are using the spectral domain or the swept source OCT domains, and the swept source OCT uses a higher wavelength of swept source tunable laser, and it penetrates deeper, provides a better scanning speed and a better resolution. But somehow the time domain has gone obsolete nowadays, and in the spectral domain we also have an enhanced depth mode which provides you a deeper penetration into the choroidal tissues and may be equally good as the swept source imaging. Now these are the images of the time domain, spectral domain and swept source. Now the swept source image, if you can see clearly, the resolution is slightly better than the spectral domain, the penetration is better, but if we see the spectral domain in enhanced depth imaging mode as well, then also we can delineate the sclerochoroidal junction. Now there are different protocols that you should be aware of. Some will cater to the anterior segment, some for the glaucoma purpose, and some for the retinal. So predominantly I'll be talking about the posterior segment retinal assessment. Just touching upon the anterior segment protocols, you have a high definition cornea protocol in which you can have high density cross sectional images of the cornea at the desired area. You have a raster scan and you can pick up any abnormality in the different layers of the cornea. Then you have wide angle to angle scan in which you can have details of the anterior chamber depth, and you can use this in refractive surgeries, phakic-IOL surgeries to measure the lens vault as well. And then you have the angle assessment wherein you can have different parameters of the angle, anterior chamber angle pertaining to glaucoma patient, assessment of glaucoma patients. Then you have the pachymetry mapping as well, in which you can have a pachymetry map at different areas. You can have the corneal thickness. Now coming to the macular scanning protocols, so you commonly have the macular cube or the macular thickness map, in which you get a volumetric assessment of the macula. Then you have a line scan. It can be a radial 1 line scan or a 2 line or 6 line or 24 line, and you can have more denser scans as well. Similarly, you have raster line scans, which will be in a particular orientation, maybe horizontal or maybe vertical, and again the number of lines can vary in that. So coming to the macular cube scan, you generally perform this scan when you want a volumetric assessment. You want to assess what is the central macular thickness or what is the thickness in the outer zones. So you can have a ETDRS grid displayed on top of the infrared image, and you can have the values in the central 1 mm part or the central 3 mm part or the 3 to 6 mm part, and you can quantitate the retinal thickness as well as the edema which is present in the intraretinal space or the subretinal space. Coming to the radial line scan. So radial line scan and raster line scan are basically used when you want to know the details of the morphological abnormality which is there in the macula. And next you have the optic nerve and the RNFL scanning protocol, in which you get all the structural parameters about the optic nerve size and the optic nerve and the neuroretinal rim and the retinal nerve fiber layers. So coming to the tips, certain tips in acquisition that you should know when you are acquiring an OCT imaging, then you should know what scanning protocol you have to choose. So you should be aware that if I want to assess the macular thickness, if it's a diabetic patient, then I need to get a macular thickness cube and not the line scan or the radial line scan or the raster line scans. So you should know what scanning protocol is to be chosen, and you should know the right density of the scans, whether you need a very denser scan or a wider scan. That also needs to be taken care of. So suppose if we see this image, this is a 6 radial line scan, and if there is any abnormality which lies in between these line scans, then that could be missed. If there is a small PD, small CNV which is there in between the two lines, neighboring line scans, then those abnormalities can be missed. So you might need a denser line scan if there is an abnormality in between these. Again, this is a dense 5-line raster scan, and if there is any abnormality in the center of the fovea, then you will be able to pick. But if there is any extrafoveal, parafoveal or extrafoveal area abnormality, then it may be missed on this scan. Now again, this is a scan with greater spacing in between. There are 3 raster lines which are visible, but if we see the central hyperreflective abnormality which is seen on infrared, it will be completely missed on the OCT image. And then you have to choose the area of interest. So if your area of interest is the optic nerve head, or suppose in this picture we can see there is an optic disc pit, and you perform a macular OCT, then you are going to miss it definitely. So you can move your point of interest, that is your fixation target, to the optic nerve head and bring it in the center of the image, therefore choosing the right area of interest. Now to interpret, you should first check the patient identity, whether it is the same patient that you are looking at, the eye, the right or the left, and the date, whether it is the same day you want to assess the image or is it the previous or the follow-up image. Whether the scan is reliable, you should look at the strength, that if it is 6 or 7, more than 6 or 6 out of 10, then it is a reliable scan. And then the area of interest, you can look in the infrared image available to you. Then read the scan in a systematic manner, that you should first go through the vitreous, if there are any abnormalities in the vitreous, any membranes or any cells, and then there is abnormality in the vitreoretinal interface, any membrane or any traction at the macula, then the intraretinal pathologies, then come to the Brooks RP membrane, then the choroid and the sclerochoroidal junction. Now quickly, this is a swept source imaging which is there, and it clearly tells you the anatomical landmarks in the normal posterior segment, wherein all the nuclear layers will be hypo and all the plexiform layers will be hyper, and even your retinal nerve fiber layer and the ellipsoid zone and RP Brooks membrane are hyper. Now, in the interest of time, I would like to skip the examples and come to certain important things here. Like for diabetic macular edema, if you want to quantitate the macular edema, go to a macular thickness cube or a macular thickness map. And if you want to see abnormalities such as CNVM or tractional maculopathy, then you have to go to your line scan or the raster line scans. Now, a bit about the other advances that we have NFAS OCT also. NFAS OCT will provide you image in the coronal plane. So you use this modality predominantly when you want to know the progression of the disease in the coronal plane, such as in geographic atrophy progression. You can very well delineate the areas of atrophy on the C scan image, and also if you want to see how much is the circumferential extent of the edema, whether it is central involving or it is going in the periphery as well, in the peripheral part, peri and parafoveal areas, then also it is helpful. Next, you can have the wide field OCT which has come up, and you can easily image the peripheral treatable lesions and then come to know whether any retinal breaks are there or retinoschisis is there. So you can easily make out using your wide field OCT. Last, you have the intraoperative microscope integrated OCT, which is very helpful in the corneal lamellar surgeries as well as in the macular surface procedures. To summarize, OCT is a fast, non-invasive tool, and it can be used to section any part of the ocular tissue nowadays, and it should be interpreted in a very systematic fashion. You should focus on the scanning protocol which is used and the imaging quality. It should always be interpreted in correlation with the fundus picture, never alone. And with the technological advancement, you are getting newer and newer types of OCT modalities that are coming up, that is helping us in better understanding of the ocular diseases. Thank you.
Thank you, Devesh. Any question? Right. So, just one point, especially the glaucoma module. I mean, deciphering the deficiency, the defect in the glaucoma module, especially the RNFL defect, that is all color coded, right? And you get a graphic representation as well. So, from those things, you can make out whether it is green, yellow, red, as per that, whether there is a defect or not. So by simply just looking at the color coded map, one can make out whether there is a deficit in the RNFL this thing or not.
Same goes for the macular thickness.
Yeah, same goes for the macular thickness also.
Now it's time to invite Dr. Shivani. Dr. Shivani has done her MBBS and MS from King's George Medical University, Lucknow. She has done her Vitreoretina Fellowship from Narayana Nethralaya, Bangalore. She has peer-reviewed publications and co-authored 6 books chapters to her. It's to her credit, and she is the recipient of waiver travel grant in ARVO year 2017. She is a very bright girl, and now it's over to Dr. Shivani.
Good afternoon, everyone. At the outset, I would like to thank Dr. Pranav Ranjan sir for giving me a chance to present here. So I will be presenting some tips on fundus fluorescent angiography without going into much detail into the FFA. So one of the most important part is preparing the patient for any procedure. So we have to counsel the patient so the anxiety is alleviated and the patient becomes cooperative for the investigation which we are aiming for. The positioning of patient is very important because it will enable us to have a good photographic capture of the images. When we are injecting the dye, we have to go in for a slower injection of approximately 4 to 6 seconds. Injection over 2 to 3 seconds gives us the best photographs, but again the chances of side effects increases. So a slower injection over 4 to 6 seconds is preferable. So before we plan on to go for acquisition of the images, we should have a plan in mind. So it is most efficient to use a photographic instruction slip which specifies the number of color photographs to be taken of each area, where to start the angiogram from, what is the diagnosis of the patient, what we are supposedly looking for, and any other pertinent information about the patient or the fundus. Like if the patient is a patient of renal failure, what we then we have to decrease the dose of the dye which we are using. So we have to keep all these things in mind. So the most important tip is we have to acquire 2 images. The first frame of the angiographic series is always the color photograph of each eye. And before we start injection, we need to have a pre-injection control photograph, which is very important because it checks the dual filter system. So this is what we are trying to rule out when we have a pre-injection photograph. We need to rule out pseudofluorescence versus the true autofluorescence. So any attrition in the filters, like if the excitation filters in the yellow-green light, the yellow-green light will come out through the barrier filter and then will have the fluorescence there, in spite of the fact that there was no structure which was fluorescent. So a control picture is a must before we start the injection. So we need to time, so what is normal in the angiographic procedure? So we need to time the various phases. We have the various phases as choroidal flush, arterial phase, the arteriovenous transit phase, the venous phase and the late phase. Coming to the choroidal flush, it is basically we have a patchy distribution. So basically the patchy distribution is due to the lobular distribution of the choroidal circulation, and it has a deep diffuse background fluorescence. Coming to the arterial phase, which gives us the arm to retina time, which is basically 8 to 12 seconds after the choroidal flush, and it also depends upon the age of the patient and the cardiovascular status and the speed of injection. So the arterial tree fills up instantaneously and quickly. It does not have any gap whatsoever, and any delay in any segment will mean there is a vascular filling defect. Coming to the arteriovenous phase, here we can see the laminar flow. We can see 2 hyperfluorescent line along the course of the veins that depicts the starting of the arteriovenous phase, which is approximately 10 to 15 seconds. And this is the peak phase of the angiogram and the best time to study foveal avascular zone. When we reach the venous phase, the veins completely fill in, and this is approximately another 10 to 25 seconds of time. The late phase or the recirculation phase is basically more than 5 minutes, when the fluorescence is completely washed off the circulation, and then again it comes into the circulation. So it will the fluorescence will be there, but it will start to decline gradually. So basically in the late phase, we need to look for the late leakage of the dye, pulling of the dye and the staining of the tissues. So here we can see the optic disc staining, which is present in normally in the late phases. So these are the various time according to the phases of angiogram. So after knowing the normal, we need to identify the abnormal also. So the any fluorescence can be divided into 2 types of abnormal fluorescence, which can be hypo or hyper. So we need to study the course of these areas as the angiogram proceeds. This is taken from Ryan, and in this we can see hypofluorescence again can be due to a blocked hypofluorescence or a vascular filling defect. So if a retinal material is being blocked, if we are not able to see the retinal vasculature, the blockade has to be superficial to the retinal nerve layer. So it has to be in the anterior segment, vitreous, or the inner retinal layers. If the choroidal material is not seen, the choroidal fluorescence is blocked, it is either due to the deep retinal or the subretinal. We need to rule out the deep retinal or subretinal. It can be either hemorrhage. So vascular filling defect again can be at the level of retina or the disc. Retina again, it can be, we have to look for any arterial thrombus or the emboli. We have to rule out any vascular occlusion or any combination of that. In the choroidal part, we have to rule out any PCA blockade, or if there is a coloboma, because as the choroid is absent, therefore there will be a vascular filling defect. Coming to the hyperfluorescence, we need to see where we are dealing with the hyperfluorescence. In the pre-injection fluorescence, either it has to be autofluorescence or it can be a pseudofluorescence. As we all know, autofluorescence happens in two main conditions, that is in optic nerve drusen or astrocytic hematoma. Pseudofluorescence already we have dealt, it is due to the poorly matched filters. In the early, again we have to look for the retina or the choroidal. So any new vessel will lead to increased blood circulation like tortuosity, anastomosis, neovascularization, aneurysms, telangiectasias or tumor vessels. Coming to the choroid, if normally RP blocks the fluorescence. So if we have a window defect in cases of atrophy or congenital reduction, we'll have increased fluorescence. And if we have increased vascularity, which happens in a new vessel formation, that is a subretinal neovascularization, inflammation or increased vascularity in tumor, it will lead to hyperfluorescence. Late again we need to see the level, vitreous, retinal or choroidal. Again in vitreous, a neovascularization will lead to a hyperfluorescence like a cotton candy hyperfluorescence, which is indicative of the neovascularization. In cases of inflammation or tumor, choroid we have to look for the pooling or the staining. In a retina, we can have a cystoid edema or non-cystoid edema which can retain the fluorescence. Therefore, it can lead to late hyperfluorescence. So, after we have identified the normal, we need to identify the abnormal vascularization. So, neovascularization again can be at the level of choroid. So, early hyperfluorescence which goes on increasing till the late phases, it is a choroidal thing. In the retinal neovascularization, we'll see it at the level of the retina, and it is going to leak profusely in the late phases in the vitreous. So collaterals and shunts, they never leak on angiogram. Telangiectasias, microaneurysms, they all lead to early hyper and late leakage. So the thumb rule is every time we see a blockade or a vascular filling defect, we need to correspond FFA finding with the clinical fundus picture. The last task is to, we have to report our findings. We have to report the arm to retina time, AV transit time, foveal avascular zone, the size and the shape of it, abnormal fluorescence areas and their course like the CNP areas, microaneurysms, and the late phase findings like the leakage or the staining. So this is about the tips of the FFA. Sir, I had some cases also.
Just so, you can go through one or two samples, right?
So this is a classical example of a fluorescence which is like a pinpoint which is going on increasing, and this is a classical ink blot appearance. We can see the NSD in the OCT also. So coming to the, this is a ink blot, this is a fluorescence which is going on increasing in a smokestack appearance. So the important thing is in a case of we can see a lacy hyperfluorescence over here in the early phases, which is going on increasing, and this is a very classic example of a classic CNBM. So this is example of a we can see a filling defect over here and a florid leakage at the disc. So this is example of a vein occlusion with a NVD. So coming to the this is an example of, we can see a subhyaloid hemorrhage and blocked hypofluorescence in this case. So this is an example of a PDR. So this is an example of a in this we cannot see a early hyperfluorescence, but as the angiogram progresses, there is increase in hyperfluorescence. So this is an example of occult CNVM. So this is basically focal DME where we can make out the pinpoint leakages, and this is an example of a diffuse DME where we cannot make out the leakage. This is very important because we are going to, if we are planning focal lasers, we need to have a fluorescent angiography. So this is example of a ischemic maculopathy where the normal fovea is enlarged and it is irregular, and there are capillary budding also. So this is an example of a patient with vasculitis where we can see perivascular staining and CNP areas in the periphery. Thank you.
Just one quick question. What is the difference between a FFA finding and the OCTA which has come up? Any limitation of
we cannot
OCT
detect
angio?
the actual flow in the OCT angiography. It is still in the process of evolution. In the FFA, we detect the actual flow of the vessels. That is the only difference which we have. I think with due course of time, they will have something in OCTA which will also detect the flow.
Thank you, Dr. Shivani. And the next speaker we have is Dr. J.G. Agarwal. He is the Vice President of Bihar Ophthalmical Society. He'll be talking on IOL power calculation tip. He'll be giving us tips on IOL power calculation.
Thanks, my good friend Dr. Pranav has given me the chances for this session. My topic is the IOL power calculation. The major factor affecting the IOL power calculation, as you all know, that is a corneal curvature measurement and the central topography, axial length measurement. ACD and the personalized a constant and prediction effective limb position and the dry eye. We have long journey from ultrasound to source biometry. Now the standard biometry is non-contact method. Optical biometry is the choice, but we have also alternative, that is immersion ultrasound and base scan biometry if it is necessary. Now optical biometry gives the most accurate reading, most easy to get and easy available to us, and almost accurately reproducible. So it is our first choice. My choice is I have with IOL Master 700. It gives the characterometric rating with two sides. That is telecharacterometric measurement with for the anterior corneal surface and swept surface for OCTI technology direct measure the posterior corneal surface. Combining these, we give the total characterometry. This interface of IOL Master 700 giving the anterior and posterior and total characterometric reading. We have also with central 0.3 millimeter zone of the central corneal topography also gives some idea about the corneal curvature. Now there is another thing that has been given in this machine is the CWC, that is angle kappa, that is Chang varying cost. It is it is a angle between the visual axis and the center of pupil. It is important because we have usually we use some diffractive rings, IOLs with diffractive rings, like trifocal, bifocal, multifocal, and some extended depth IOL. We want to place the IOL diffractive rings in concentric, to be concentric with the central and patient's visual axis, so as to the center of the pupil is as influence performance of the diffractive ring. Ideally, we give the best visual performance and the best satisfaction to the patient if the his value is low. So at this point I want to convey you that CWC reading is should be below 0.6 millimeter, otherwise you will get the distorted images. So I will prefer with 0.3 to 0.4 millimeter. But the limitation of optical biometry are the mature dense cataract, fixation difficulty, tremor, nystagmus, and there at this situation we go for the immersion methods. It is the ultrasound method, but it is a non-contact. So most accurate, the no corneal decompression, but the method is with optical was calibrated in this development. But there is a difference between the measurement of the axial length. In the A scan by ultrasound, we go up to the foveal cup, but for the biometry, optical biometry, we go for the retinal pigmentary layer. So difference is 150 micron. But now come to the recent IOL calculation formula for accurate result. We have Olesen formula, Keynes formula, Barrett Universal 2, Hales RBF, and Leda Super. These are the newer formula. I am not going to for the other older regression formula. Now just only one line, that is Olesen formula. Here is the C constant, and it eliminates the relation to the E expected length position with K axial length and white to white. So it is better as it is eliminates the relation with the expected lens position. And next is the Keynes formula. It is artificial intelligence with the theoretical optics. Here we have three variables, and it accurately measures all the range of axial length, smallest absolute error for the long eye. So it is very accurate, gives the accurate result in almost all situations, and it is better than other formulas. We claim to be the most accurate than other, but needs cohort study and validation. This is the publishers for the Keynes formula, but it needs validation, no doubt. Now we generally use Barrett Universal 2. It is a theoretical model. It eliminates the estimates the expected length based on the anterior chamber depth and lens factors, and 5 variables are there. It addresses the different IOL shape and offers adjustment required for the low and high IOL powers. Hill RBF, it is artificial intelligence based formula. When when we upload the data of the patient, HEAL RBF finds the distinct pattern in the apparently random cloud of data points already created by the large number of cases. So that is the pattern recognition based on the artificial intelligence. Artificial based HEAL RBF form method is a pure data-driven calculation approach, and therefore it is free from the limitation of lens position estimation, and free from the limitation of inherent of standard formula. So it gives the two types of result. Inbound, prediction is very good, but outbound does not only gives does not matches the what is given in the inside the software. So even it is though it out of bound, but it is good. It is an interface of the HEAL RBF calculator. Now LADA super formula, it works on the based on the sweet spot. Sweet spots are the maximum correct spot responses for a given amount of input. So here we can create the HEAL LADA super surfaces. It based on the 4 formulas: Hopper Q, Holiday 1 with Wang Koch axial length adjustment, and Aggies. Now it is the interface of LADA super formula. With the inclusion of the 3-dimensional graph as shown in this slide, the surgeon knows instantly that if he is handling the typical or unusual eyes. LADA super, if it compared with the Barrett universal formula, if for the extreme size that is shown in the red area, LADA super is better than the Barrett's universal formula. Now, if you for the comparison regression formula, there is a beautiful article by Mailer, Holiday, and the Chang. Here, which formula is most accurate in all ranges of axial length? It shows that the Barrett and the Olesan is better, and same thing is for most accurate range for all ranges IOL, and it here again the Barrett's and Olesan is better. Now, which formula is more accurate than eyes with the average all the range of anterior chamber value and the eye and all the anterior chamber depth? Here again, Barrett is better than other. Now, for extremes eye, for one Koch adjustment with the Holiday 1 and Keynes the Barrett formula is better. For short of hypermetropic eyes, again, Keynes formula and Barrett HEAL RBF are better. So, in short, we have Keynes formula, Barrett, and HEAL RBF. It is better than any other formula.
Dr. Agarwal,
yes,
with the paucity of time,
these are the for the post-refractive cases. Here, ACRS calculator is better than any other. So, if it is when the biometry in the silicon oil filled eyes, here again we have optical biometer with the one is where we can also get the optical coherent biometry in the silicon oil mode, where we can get the good result. So, conclusion: the perfect biometry is utmost important. That is, swift source of biometry is the instrument of choice. Better to take the reading in a dioptric power in a plus rotation, as it is important the incisional management of astigmatism using the coupling effect. It is important to use newer formula like Barrett, EVO, Olesan, Keynes, RBF, LADA super. Formula should be free from the limitation of the lens position estimation, because it gives all problematic results. The Barrett and Barrett universal is the most popular formula, though it is though here the calculation of expected length position is built and more accurate. HEAL RBF, LADAS, and CAN are the very good formula, and it is improving over time. Still, we are improving to get the better result. Thank you.
Thank you so much, Dr. Jayagopal Agarwal.
Yeah.
Because of paucity of time, we have got only 5-6 minutes left. I'll just briefly go through the tips of perimetry.
Yes. Dr. Pranav Ranjan is going to present on the topics of perimetric pearls. He is a brilliant practitioner in the from Patna, and he has passed his MBBS and MS from the Patna, and now he is the president of Bihar Ophthalmic Society and also the AIOC society of for Eastern Zone Society. It is very is a very upcoming society, and he is the president of that society. Now over to Pranav Ranjan for
thank you, Dr. Agarwal. Perimetry, we have to consider few facts before we go into the interpretation. We get into certain definitions like threshold. What is a threshold? It is a particular intensity of light which is seen 50% of the times. Supra threshold is seen 90% of the times, and infra threshold is seen 15% of the times. There is a stat pack analysis which is done with the Humphrey, and it is a computerized software which is based on normative data. The 5% lower normative data is bracketed as abnormal, and what we do is we compare the normative data with the present data that is collected from the present patient. This is also important. P-value is important because we have to interpret from the p-value also. And what is a p-value? It is a probability percentage. What is a probability percentage? It is assigned as 10%, 5, 2, 1 and 0.5%. For example, what p less than 1% means? P less than 1% means that this defect is seen only in 1% of the normal population. Other way of describing it would be, it is not seen in 99% of the normal population. So you have to consider this. There are two aspects when you are doing a autoperimetry, that is a point pattern, the point in which the tests are done, because this is a static, automated perimetry is a static perimeter, and the strategy, what kind of a strategy of throwing the light is given to the patient. These are the common test patterns which are followed in glaucoma. 30-2, which has got a 76 test points, 6 degrees apart. 24-2, again, which is a shorter form of 30-2, which has got 54 test points. Both of them are of equal value, but the advantage of 24-2 is that it takes lesser time, and the sensitivity as per the glaucoma is concerned is almost equal. So we generally prefer a 24-2. For advanced glaucoma, we have a 10-2 point, which has got 68 test points with distribution pattern of 2 degrees. Macular program is just 5 degrees and a nasal step. These are all the tests which are confined to glaucoma testing. The second one is the strategy that we have to take into account. We have two strategies. The older strategy, which was known as a bracketing method, and the newer strategy is the new threshold strategy. In the older strategy, the stimulus used to travel 2 times across the threshold value with a value of 4 degrees apart, and then while descending back, it used to reduce by 2 decibels. So it had to cross the threshold level twice, but the final resolution was 2 decibels. Whereas the newer threshold, it crosses the threshold level only once with a decibel difference of 3 decibels. So the final resolution is 3 decibels, but the results that we get, we save at least 40% of the time, and there is hardly any significant change in the final outcome. These are the checklists which one has to take into consideration, and we'll just go into the single field analysis which we see in the Humphrey field. For convenience sake, we have divided into 10 brackets, 10 groups, 1 to 10. The number 1 in the single field analysis, the area 1, which has the name, age, I selected, and the test which has been selected. One thing which is important is to enter the correct age, because the correct age of this particular patient is going to be compared with the normative data which is already stored in the computer. So the age has to be correct. The second area is the area of reliability factors, whether the patient is able to concentrate on the central point or not, is losing his fixation or not. So we have got 3 points here. One is a fixation loss, the second one is false positive, and third one is a false negative. What is a fixation loss? Is measured by placing 5% of the computer places 5% of the total number of stimulus that is given to the blind spot. Any error which is more than 20%, we cannot take it, it has to be discarded. False positive means there has been no stimulus, still the patient has pressed the button, has a positive response, and anything which is above 15% is unreliable. False negative again is a missed response because of fatigue of the patient. Area number 3, 4 and 5 has the foveal threshold, the stimulus size which is standard Goldman 3, the background illumination which is standard 31.5, the strategy that has been selected, the Sita fast or Sita standard, the pupil size, visual acuity and the diffraction. Coming to area number 5, which is the most important area, this is the raw area, area of raw data along with the gray scale. So what it does basically, It gives you a generalized picture of whether the field is abnormal or normal by giving black to white shades as per the sensitivity of that particular patient. So coming forward to area number 7 is the area of total deviation. So area of total deviation is nothing but the point-to-point difference of the normative data of that particular patient in comparison to the present data of this patient. So what you see here, x-axis is the normative data, which is compared point to point with the raw data, and the difference between the normative and the raw data is given in total deviation numeric plot as well as the total deviation probability plot. So this is point to point difference. So coming to the pattern deviation numeric plot, this is derived from the total deviation plot. What is done is that the total deviation can be because of a sensitivity loss because of cataract, corneal opacity and vitreous opacity and other things. So that has to be differentiated and that has to be eliminated, and glaucoma specific can be done only when they are eliminated. So this pattern deviation numeric plot, by applying a stat pack analysis, that gives you the idea in numeric values as well as the probability plot value. And how it is done basically is that in the 24-2, which has got 54 test points, 3 test points near the blind spots are ignored, and of the remaining 51 points, the 7th best point is adjusted to 0 and the other points are accordingly adjusted. For example, what we see here is that the 7th best point in this total deviation is -6. It has been adjusted by adding +6. It becomes 0 on the pattern deviation, and accordingly the other points, like just beside -6 we have -3, becomes 0, becomes 3. So this is how it is adjusted. Area number 9 is the GST, which is the most important. It has 5 mirror images in the superior and the inferior sectors. They are compared to each other. This is very glaucoma sensitive, and it is flagged in by 5 definitions, like outside normal range, borderline, low sensitive, high sensitive, within normal limits. The area number 9 has got 3 parameters. The mean deviation. Mean deviation is nothing but a single number which is an average of the total deviation. So what we see in the total deviation here, the average of all the points is given as a single total deviation point, right? And it is given as a probability plot, defined as a probability plot also. Pattern standard deviation is the difference between the mean deviation number and the pattern deviation number individually. So if there is larger difference, the larger will be the PSD, and the larger are the chances that the field will be glaucomatous. The third, which has been incorporated around a decade back, is the visual field index, which is expressed as in 0 to 10, 100%. 0% means blind, 100% means which is normal. It incorporates both the total and the pattern deviation data. It gives weightage to the pattern deviation and central points, provides an estimate of field loss in the next 5 years. Anderson's criteria, this is one of the most widely used criteria to define whether the field is abnormal or not. PSD depressed to be seen in 5% of the population. GHT outside normal range. 3 or non-edge points in pattern plot to be seen in less than 5% normals, of which one should be less than 1%. And it should be present in 3 consecutive fields. So these are just examples. Inferior arcuate with a nasal step, inferior arcuate with a nasal step, double arcuate, advanced glaucoma with an annular scotoma, advanced field loss, annular scotoma again, a glaucoma with a cataract field loss is seen like this. This is a bitemporal hemianopic field, the neurological fields which you can see, the homonymous hemianopic field. This is a RP patient of 30-2 and full field, just a pattern. And this is the comparison between the normal and the abnormal. On the left side, what you see is the normal. The right side you see is an abnormal inferior arcuate with nasal steps. Unless you understand what is a normal, you will not be able to differentiate what is abnormal. Thank you so much for your kind attention. Can we have a photograph of the speakers and all?